we can see here, we finished off talking yesterday about these nerves and how they can play a role in the range of motion of the hip. So the femoral nerve syndrome we see when the person has running loss forward swing and starts circumducting the leg with external rotation. For example, we can see weakness of the quadriceps as a result of impingement of the femoral nerve at the inguinal. Also, if you carry something heavy and you rest it on your groin to open a door, or you are having something heavy here whilst you walk or carry it, lifting a box that pushes into it, you can damage the femoral nerve. And what you will see then is that the iliacus is weak. The iliacus is strong because it's above the inguinal ligament, but the quadriceps and sartorius is weak. So you have weak quad, strong iliacus. And the painful quadriceps muscle belly. You can stress the inguinal ligament together or stretch it, and whichever one makes the quad strength better is what you will treat at the inguinal ligament. Okay? You can also treat the abdominal wall because that inguinal ligament is the bottom part of the abdominal wall. It's just a folded remnant of the abdominal wall. So any exercises that will strengthen the abdominal wall are going to be used, especially in addition to treating the ligament if it is too tight. If you need to stretch it out and release it, then you will also do that will help with the abdominal wall strength, and you will strengthen the abdominal wall and give it exercises to keep it going. You treat again bracing problems for this syndrome. So the femoral nerve syndrome, or the caused by entrapment of the hypertrophy of the iliopsoas, or engorgement of the iliopsoas is what you see. So someone who's running a long time, or who does ballet, must lift the leg up and down, or a gymnast can start to get problems with the strength of the quads. So this is what this is about. Okay. The other thing you might find again is pinching, limitation of motion, and early abduction of the hip. So when you have this problem, you must look to tightness of the piriformis, for example, and the external hip rotators. So we can see limited internal rotation, and we will have to differentiate it from limited internal rotation due to end range of the joint, as opposed to limited internal rotation due to tightness of the external rotators. Let me just check something here. Okay. So, if I have a tight piriformis, limited internal rotation in prone, and I have pinching of the hip, I usually am first treating the external hip rotators, and I'm checking for anteriority as we did for the hip joint. And then I would treat the piriformis or the external hip rotators, do the wishbone maneuver, and come back and check the mobility of this function. Now, as I said, if this is due to the actual joint, like I have a impingement, bony impingement, then of course it won't really It may change, but it may take longer to improve because I have some obstruction in this. On the other hand, if I have, for example, femoral acetabular orientation problems, it won't improve, and I must be careful to stop trying to make it improve. So remember that if I have retroversion of the acetabular cup, it will block flexion and adduction. And the hard end feel and no improvement on treating the soft tissue should be a warning to you that this is probably a retroverted acetabular cup, and that if you try to do more, you will probably damage the joint and not help it. So that is the differential diagnosis. And the same as when you have an anteverted acetabular cup, you'll have limited hip extension, and the femur will be blocked into extension, and you have to stop trying to jam it into extension. So the hard feel, the lack of response to any stretching or mobilization should be a warning that you probably have a joint position or version problem, and you need to have the X-rays, the appropriate kind of X-ray or radiographs done to check for that anomaly. When you have the obturator nerve can be impinged by prolapse or ptosis of the abdomen or uterine prolapse. These people lose strength in the adductors because the obturator is obstructed, and soreness of the adductors can mimic hamstring pain. If you test the adductors normally, and they are strong, and if the person then does a Valsalva and pushes the contents against the obturator foramen and the obturator nerve, then the adductors will test weak. You can also have patients who complain of leg pain, and I have a patient now who has had chronic foot and arch pain. It mimics plantar fasciitis, and she's had everything done to her foot. She's had orthotics, injections, all bilateral pain, and she has nice feet. There's nothing wrong with her feet, but she does have ptosis of the abdomen lying on some of the nerves in her groin, and it makes her feet hurt. So if she's up on her feet all day, they just progressively get worse. As soon as she doesn't have to be vertical, the feet start to get better. So what we did was test the tenderness in her foot, do the adductor test, and then we did this inguinal unloading. So the inguinal unloading is important to know when you have to go. Is the symptom in the leg, whether it is proximal or distal, coming from anywhere near here? You have to open the space and pull the viscera away from the inguina and see if it changes anything. So, yes. Keep an eye on your back, please. So, we had talked about your having in this area some tenderness, yes? So he has this obturator sign of tenderness of the adductors. So the area can be local It can be regional in the obturator foramen. It can also be up here. So he's going to bend his knee. I'm going to take one hand and scoop the viscera away, using the other hand to push. So this hand is not irritating, and the irritating push is going through my softened hand. So I go, and just above the inguinal, I place my hand like this, and then the force comes from the other hand through my softened back of my fingers. Because if I did this, he would stop me. But he doesn't need to fear the soft back of my hand, and this is going to pull the viscera away from the inguinal canal. Now, I can keep that there. I go back and I ask him if there's any change.
Yeah.
Yes?
Is there?
Mm-hmm.
Yeah.
Significantly.
Yeah. And then I let him go. He can lift his head and give me a Valsalva by come up a little bit more, come up. Yes, good, good, good. And go back down. And I go back and I go, is this any tender again?
A little bit.
A little bit, but there it is again. Okay, so come please and put your finger there so we are sure of what we are doing. Okay, so I'm going to do this. I'm going to repeat this again. And then, good. Okay, good. Now rub it. Is that better? Give it a good rub like you don't like him.
She definitely doesn't like me.
Is it painful?
A little bit, yeah, but less though.
Less than before. So it is this kind of, yes, it seems more relaxed than the tension before. So it is this kind of differential diagnosis that you must be able to do. Are the symptoms coming from the neurovascular bundle that goes through the inguinal foramen?
What would they need to do? Just lose weight or something? Or tighten
Sometimes
up?
you need to improve the lower abdominal tone.
Okay, so.
Sometimes you need to mobilize the viscera away. The connective tissue allows the viscera to be very close or tight to the inguinal passage, and therefore when they run or they do anything and the psoas swells up or they walk on, it has no space.
Oh.
Yes? So it's like when you get it's almost like you're going to get a hernia, but you don't have a hernia. You just have enough pressure of the viscera in that area, but it's not a hernia.
And it is counterintuitive because rather the bracing and the breathing would help this situation.
Yes, which
You
you
would
would
think
think
that
it would make it worse.
But it just,
But
yeah.
the bracing and breathing correctly neutralizes the pelvis and stops the viscera falling forward. Yes? It falls down into the basin and not a little bit forward and onto the opening rim. Yeah. So that is why it seems to work. But normally they'll brace harder and then it'll get better. That doesn't make sense. Yeah. But that is it. So this is inguinal unloading. You can test the adductors for loss of strength, palpate, and then you can do a Valsalva, see if it makes it worse, makes it weak, and then if it does, you pull this up and you retest. If the tenderness is if the problem is at the obturator membrane, then you will have to go up the side along the ischial ramus to the obturator opening for foramen and release it there. So those are your differential diagnosis. And then the other aspect is that you have Escape.